Students are able to take a post-shadowing assessment and receive a certificate verifying their hours. This post-shadowing assessment will take place right after the scheduled session time. So today that will be 7 o'clock p.m. Pacific Standard Time. So just please ensure that you guys are taking good notes. This is something that you're going to want to remember when you are applying to the programs you're applying to in the future. You want to really extract something meaningful from these opportunities, even though we're not in person. So just keep that in mind. And that is all I have for you. So thank you everybody for joining us today. I am really excited to welcome to you an OB hospitalist, Dr. Jennifer Lincoln. Welcome.
Oh my God, there's so many of you guys here. I love it. All right, let me share my screen and then we'll get started. Let me just, let's see. All right. Does that look good for you, Nina? You can see that okay?
Looks perfect. Ready to go.
All right, cool. All right, guys. So yeah, I'm just going to jump in and get started. So my name is Jen Lincoln, and like Nina said, I'm an OB hospitalist, and we will talk more today about what that actually means and how it's different from a generalist OBGYN. And I'm so excited to be chatting with you guys here today. My contact information is down below. You can find me on social media, and then I'll put it up again at the end too, in case you want to follow along. And I think that in this crazy time when you can't get into the hospitals, or interact directly with so many physicians or nurses or physician's assistants, being able to see what our lives are like virtually can be really helpful. So hopefully you'll follow along. So I have some disclaimers because where would I be without disclaimers? That I have no financial incentives. I'm not getting paid to do this talk. All my content is my own and does not represent any opinion of my employer. And I'm not giving any personalized medical advice here when we do talk about some cases. And there's no violation of patient privacy here. And there will be, you can drop questions in the chat is my understanding, and then the moderators here will be able to ask and accumulate them as we go along. So I'll talk for the first bit, and then we'll do a Q&A at the end. So if you've got questions, feel free to let me know. So this is my general outline because I'm a type A OBGYN and I like to know where I'm going. So I'm going to give you a quick background about me and kind of where I came from, and then why medicine. I think that meaning or that reason people go into medicine is kind of different for everybody, but why I chose it. And then getting into med school, how I did it and my tips for you. And then just an idea of my professional life and my personal life, because I think that it can be really hard sometimes to know what it's like, what is the actual day to day? I get a lot of questions. People are like, how do you do this? How do you do that? So just kind of an idea, a glimpse into kind of what my life looks like. And then for me personally, why OBGYN? And then how to become an OBGYN if I convinced you by the end of this that that's what you want to do. We'll go through a day in the life and then 2 patient cases and then a Q&A. It sounds like a lot, but it's not, I promise. And I would much rather interact with you guys and ask your questions than me just, blather on. So hopefully it will not bore you. So a bit about me. So I'm from New York originally. I saw there was somebody here from New York, but now I'm getting older. And so I've actually lived out of New York longer than I've lived there. And so I grew up, I was born in Queens, and I was the only child of 2 teen parents. And I thought I would never leave the East Coast. And now I live on the polar opposite. I live on the Pacific Northwest. But when I was in New York, I thought there was nothing else outside of New York. And I loved it. I grew up on Long Island and went to Catholic school, and that I think becomes relevant towards the end of this when it comes to how much I enjoy teaching people about their bodies and specifically sex education, because I got like none of it. But anyway, then after New York, I went to Maryland. And I went to Washington College on the Eastern Shore of Maryland, which is a small liberal arts college. When I was there, I think there were maybe only about 1,000 students. So a pretty tiny place. And let's see if I can move this. Okay, there we go. I did get my bachelor's of science in biology, and I minored in chemistry and English. And I will be completely honest with you, the only reason I minored in chemistry was because it was only, I think, 2 or 3 extra classes after doing a biology major. It's not that I had this major passion for chemistry, but I figured why not? And then English for me was my fun thing. I love to read, I love to write, and I think that's why I enjoy medical writing and communicating so much. But I absolutely love British literature, historical fiction. And so that was sort of my fun part for me. And we'll talk about that later on when you go to college. And when you're in college, being a pre-med was definitely a huge part of me, but it wasn't the only part of me. And I think it's important that you keep something for you. And I was active in Greek life. I was, or I should say I am a Zeta Chi Alpha. And some people are surprised when they hear that you can, kind of do more things than just be pre-med. And I'm sure plenty of you here are doing, are very active in your college campus. And for me, being active in my sorority, I think was awesome because it taught me to multitask. I held leadership positions. It taught me how to network. And my sorority was very much, I don't know. I mean, it wasn't like the typical whatever. I mean, we were so good academically. We really encouraged each other. My sisters, they're amazing. And in fact, one that was went into nursing and worked at Johns Hopkins Shock Trauma. Now actually just moved out here a couple of years ago, and now she's in Portland with me, and she's working as a nurse practitioner, and it's just super fun to have those connections. I also love journalism. I wrote for the school newspaper, and then I was one of the editors for that. So again, just that fun part for me that had nothing to do with science, but I totally it was my break. And then I graduated summa cum laude, and I worked really hard, but I was not perfect. And then I went down to Louisiana. I don't know if anybody's here from Louisiana, but I went to medical school at the Tulane University School of Medicine in New Orleans. And this is where life got interesting. I volunteered in a bunch of homeless shelters and reproductive health clinics in my first and second year of medical school. And I think it's really important that you look for those clinical correlations and those opportunities, not just when you're a pre-med, but when you're in med school, those first 2 years too, because there's a lot of information and it can be really hard sometimes to remember the end goal. And so I think it's really important to get yourself around patients as much as possible, to remind yourself why you're studying so hard biochemistry or genetics or whatever. I was elected to Alpha Omega Alpha, which is the National Honor Society in medical schools, and I survived a hurricane. So when we were there, we had this oh, that's my white coat ceremony. This is back in the day, guys, when we didn't have smartphones, which was making me seem so much older than I want to admit. But this was the day that I got my white coat. So when you're a medical student, you're given a white coat, a short white coat. And this, I just remember feeling like, oh my gosh, I had made it and my dreams had come true. And it was amazing. It was only the beginning though. So then we had this little hurricane. And this is a picture of my medical school, the entranceway, the first floor, and that's all the duct equipment to try to dry it out. So I was there during Hurricane Katrina. I was a third year medical student. And I think this is relevant. And I want to pass on this positivity to you. So going to medical school during a hurricane, we were evacuated, school closed down for a couple of weeks. We ended up in Houston. I ended up doing some of my clinical rotations in Houston at the Baylor College of Medicine. And it was kind of crazy, which is kind of like what life is like right now. And I know that you guys are missing out on so much. You're missing out on this in-person interaction. You're missing out on the opportunity to work directly with people. You probably feel like it's totally upending your plans. But I will tell you, there was nothing that people wanted to talk to me about more on my residency applications than how I survived Hurricane Katrina and managed to do medical school throughout all of it. So I know everybody's going to be talking about this, but truly it's a strength because I know my program directors, when they heard that I could do this and still do great in school, they're like, she can handle residency. So the fact that like you guys are doing this stuff, you could be totally screwing off during a pandemic and just doing whatever. Like I was joking with the team here, like I'm just sitting around eating Oreos. I feel like most days I'm watching Netflix. Like use this to your strength and show that you can persevere when times get hard and get creative and be flexible. Like how awesome is this opportunity? So I'm kind of right there with you. So I feel for you guys, but you will get through it and you'll divide your life into the before and after, and you'll be stronger coming out of it. But we made it. That's my husband. He's a pediatrician. That's back in the day when we were young. We graduated and we then couples matched. So when you're matching together, you can choose to match into residencies, and that's a whole other talk. But long story short, we couples matched into our residencies here in Portland, Oregon at Oregon Health and Science University, where I did my OBGYN residency, which was 4 years. But we didn't just do residency. We didn't just work a crazy amount of hours a week. We bought our first house. We traveled a lot. We had our first baby when I was a chief resident. And every step along the way, like I said, I thought I'd never leave New York. Step took from different parts of the country and learned so much. So I really encourage you to cast a really far net because there was no reason I should have come to Portland, Oregon to interview. It was just, we were like, hey, that sounds like a cool place to be. I had no connection here and we absolutely loved it. And now I work here and I will never leave. And that is my residency graduation certificate on my last day of residency, which you can imagine felt pretty amazing. So So yeah, so why medicine? So I don't have any fancy slides about this, but for me, my story about why medicine, I don't know, I don't have some amazing, I had this surgery and it was life changing. Honestly, my parents told me that I should be a doctor. And I think that they did that because they were teen parents. They had very little money. They came from very difficult backgrounds. And they're like, oh yeah, doctors like have great lives. And I internalized it. And thankfully, I really then wanted to do it. So it's like I had the seed planted, but I actually wanted to do it. And the reason I bring that up is because there might be some of you here today who are being told you need to go into medicine because it's the only respectable career, or it's the only way to make money, or your brother went to medicine, or your dad's a doctor, your mom's a doctor. And I'm telling you, only do it because you truly want to do it. So for me, I truly did want to do it. I was really interested in science. I loved interacting with patients. I love the pace of it, but it's not easy. And so just make sure that your why is the right why. And I'm lucky that had I not, maybe my parents had said, oh, I should be a lawyer. Maybe I would have thought that too, but I think I would have found the path. So I just got lucky. There was a very brief time between high school and college when I thought I would do medical writing instead of medicine, because I went to a conference, the National Youth Leadership Forum on Medicine, which I think is still around. And I went to one in Boston, and there was a bunch of these Harvard medical students, and they were like giving us like a 1 hour talk, kind of like this, but they were so miserable. And they were all equally miserable. And it's not because Harvard makes miserable, they just themselves were. So I don't want to say anything bad, but so I left that. I'm like, okay, I'm not going to be a doctor. Those people are, crying. Looks like they are having the worst life ever. But I love writing, so I'll do medical writing. And then I started college my freshman year, and within like a few weeks of taking microbiology, I was like, oh no, I do really like this. So it's okay if along the way you have some doubts, and that's why doing things like this, interacting with actual people in the hospital, in the office, just to see if it's what you want, I think is really important, because once you do go down that path, it's a really expensive path to not complete when it comes to preparation and schooling. And I think it's really important to understand that when I say why medicine, for me, it's why I wanted to be a physician. But understand there's lots of different ways to get into medicine, whether it's being a physician, being a nurse, being a physical therapist, respiratory therapist, physician's assistant, nurse practitioner. There's so many different pathways. So do not think that you have to be a doctor, and think about what it is that you want, what you're willing to tolerate, the amount of training, salary, flexibility, at the end of the day, responsibility. Where do you feel comfortable? And then that can kind of help guide you along. So getting into medical school, which I think is probably most of your guys' focus right now, because I know when I was pre-med, that's all I cared about. It's like, just tell me how to get in, because I need to know, because I got to get in, because like that's, then after that, like I can figure it all out, but I just need to know the secret on how to get in. And the secret is that there is no secret. But I will tell you that you do not need to be perfect, and I certainly was not. And me listening, you're probably like, well, that's easy for you to say now, right? Because you're there, and I fully acknowledge that. But and I think if I was talking to myself back then, I wouldn't believe myself then either, because I felt that I had to be perfect. But that kind of pressure can really throw you off course and can make you believe that the only people who get in are the ones who are perfect at everything, and nothing can be farther from the truth. So yeah, you do need to work hard. I mean, I'm not trying to tell you that you can just kind of screw off and get middle of the road grades, but you'll write a great essay and you'll get it. No, you do need to work hard, but at the same time, you do need to have fun. I had plenty of fun in college, and I worked really hard, and I think it's about the balance. And it's important because I don't know about you guys, but the doctors that I cannot stand are the ones that, I don't care how smart they are, if they have the personality of a cardboard box, like I don't want to go see them again. Like I don't want to, I'm not going to trust them when they make a recommendation if I don't feel connected to them. And part of that, is being able to have fun or just be a real person. I know that's the kind of doctor I try to be, and that's the ones, that I go to and that I take my kids to. So I think, it's about a balance, because if you don't, you're just going to burn out and quit. So do the best that you can in college, but you don't have to major in the sciences. I get this question probably every day on my Instagram and my TikTok. Feel free to major in it if it's what you're interested in. And don't feel that you shouldn't major in it because you should major in something else to make you more interested. Like, don't play the games, just major in what you love, and know that you do need to have certain prerequisites. And unfortunately, physics is one of them. If there's any physics majors who are listening to this, God bless you people, because that class almost did me in. But you don't have to major in biology or chemistry if you don't want to. You don't have to do it to look good on an application. I tell the story that I took a biochemistry class in college, and it made it easier when I took biochem in med school. But just to give you a frame of reference, what I learned in med school, that whole semester in college, I learned in 2 weeks in medical school. And maybe it was slightly easier because I already knew it, but I would have learned it anyway. So the volume of what you're going to learn in med school is so much beyond what you're going to get in college. It's great to give you a basis, but truly, if you want to major in communications or, you know, philosophy or dance, like go for it. Because when you go to med school, you're going to get everything you need. College is the last chance to really do a lot of that other stuff. It's like when I talk to medical students who want to do OBGYN, they're like, so I'm going to do all the OBGYN electives my 4th year of med school. And I'm like, don't do that. That's really stupid because that's what your whole residency is going to be. Like maybe do 1 or 2 to make sure it's what you want to do, and then do everything else. Because never again will you get to do emergency medicine or critical care or surgery or whatever. So enjoy college and take the classes that you want to, and only major in science if you really want to. Prep for the MCAT as best you can. Now, I have no shame in sharing this. I did terribly on the MCAT. And I don't remember my score. And it's not because I don't want to tell you, because I would if I could. I even tried to look it up and I couldn't even find it. And now the scores are different too, back to, compared to when I took it. I did absolutely terribly. I remember opening up the score and I just said, there we go. There's my dream. It's just down the toilet because it was so bad. Um, and and I applied anyway. I decided to apply anyway after talking to my pre-med advisor, and because everything else was strong, my grades and my letters of recommendation. I figured, what's the worst that can happen? I don't get in, and I spend a lot of money in the meantime. And I got in. It definitely narrowed down how many interviews I got. There's no doubt about that. But I addressed it in my interviews and I addressed it in my essay. I mean, I didn't sit there and, make a whole sob story out of it, but I was like, hey, I did really poorly. Here's why I think I just didn't study well enough. I could have done better, but here's why I'm still going to be a great physician. And let's look at my GPA and let's look at all of this, because this is more of a longitudinal marker over time of the, of how successful I think I can be. And I think that worked. But nowadays, again, I'm aging myself. I feel like there's so many good resources online. I went to college in a very rural part of Maryland, and to take a prep class, we had to drive like an hour twice a week, either way, to get to the University of Delaware to take our prep course, and it was a pain in the ass. And so now, you can do these things online, which is great. So prepare as best that you can. But if you do not do great, it doesn't mean it's the end of the road. It doesn't mean you can't apply. It doesn't mean you can't take it again. And then I think what's really important is figure out a way to stand out. Volunteering is great, starting a club or a nonprofit. The point here is that you should be active in something, but don't just show up and be a passive member. Go above and beyond. So maybe you want to volunteer at a homeless shelter. That's awesome. But then get into a leadership position. Or maybe you decide that the shelter needs, I don't know, a reproductive health access course or something. So just try to be active, because anybody can show up and join a club, and you can check the box on your application. But what makes you stand out and shows that you can be a leader and take some initiative? Now, when I went to med school, we had our first day of orientation, and imposter syndrome is real. I mean, even to this day, I feel it. So if you guys will feel it too. And the dean's going through and he's like, so we've got an amazing class. And he went through all the statistics and he's like, and we have, an ex minor league baseball player, and we have so many number of people retired from the military. And this person started a nonprofit in Ghana and blah, blah, blah. And I'm sitting there and I'm like, what the hell have I done? And I think that it just goes to show that nowadays there's so many opportunities to stand out in that realm. So if you can do it, go for it. And just try to set yourself apart, but don't just do it just to check the box. Truly find something you're passionate about. And again, it does not have to be related to medicine. Maybe you're really interested in being politically active or in advocacy, and just do it and have fun. And then you'd be surprised where it kind of lands you. That might become the basis of, the field that you want to go into in the future. And then don't be afraid. Let me just move this here so I can see. Don't be afraid to address your shortcomings. I think I've kind of addressed this already. Like I said, I called out my MCAT scores because they were going to ask me about it anyway. So I'd rather play offense than play defense. So I think you're going to have shortcomings. You're human, and that's okay. And don't be afraid to address them. And make sure this is the career that you want. Again, before all of these things, stop and really think. And I've kind of talked about this before. And there are people who don't make it, but the majority, once you start med school, they tend to complete it and do residency. But you can tell the people who really love it and this is super fun for them every day versus those that are like, oh, I wish I never should have gone to med school and blah, blah, blah. And I just think it's important to step back, just make sure you're doing it for the right reasons. And it is totally okay if you need to tell your parents, like, you know what, I'm not doing this, or I'd rather be a nurse, or I'd rather be a PA. There's no shame in that. The world of medicine, we need everybody. Um, I am going to take this moment just to make a quick note on social media because I feel that I'd be really remiss if I didn't bring this up. I'm so glad that I didn't have to worry about this when I was applying. But I want you guys to be really aware that your social media is fair game when it comes to applications. And it's a very small world out there. And I'm not saying this to like threaten you or anything, but just to make you aware. Um, Everything's out there, everything's fair game. Yes, they're looking. And if you put stuff out there that makes you look not professional, it could get noticed. And I'm not saying that's right or wrong because of course we all have fun and we all have lives. But just when you're going through the application cycle, you may want to decide whether or not your stuff is public, even down to your profile picture. If that's the only thing people can see, does it put you in a positive light or a negative light? So it's just really important to just think about that. And this was on the AAMC website. And I think you guys are pretty smart nowadays. I mean, stuff can get found out. But you can also, your social media can actually be something that's really awesome. Like maybe you've got an account where you share lots of interesting things and you use it for advocacy or, for something like that. I mean, it could actually be a positive and that might be something you want to call attention to on your application. So just to be mindful of that. So I want to give you a little glimpse into my work life. I'm just checking time to make sure I'm not yammering on too long. So I'm an OB hospitalist. So that is something that maybe you guys have not all heard about. So an OBGYN hospitalist is an OBGYN who specifically cares for a hospitalized woman. And I say woman, and I know that not all, pregnant people identify as women and vice versa, but I'm going to use that term here, but I do acknowledge that. So that means that we only work in the hospital. So we are considered kind of the experts in inpatient medicine when it comes to OBGYN. And I was trying to see what I had next. I think I actually explained this a little bit more in a different slide. So what this means for me is that I work shift work. I am not in clinic. I work 12-hour shifts, days or night shifts, and my schedule is super variable. I'm also part-time, which I think is really important to highlight. I did not start out that way, but I am now. And I love it. So medicine's awesome because it's a totally flexible career. And you can change it as your needs change. But because I'm part-time, I can do these other things. So I'm the medical director of a postpartum care center. So that is a clinic that we have associated with our hospital that cares for breastfeeding women and newborns in the first few days after they're discharged home from the hospital. So we're like a safety net. So if a mom goes home and is having breastfeeding issues or she has blood pressure issues, she can come in the next couple of days and we can check her out, and then we can continue to offer that breastfeeding support throughout the entire time. And the reason I'm doing that is because I'm an IBCLC, or an International Board Certified Lactation Consultant, which is a whole story into and of itself. But I just realized that I did not get enough of that in medicine. And so I pursued separate training on that, which involved, I can't remember, I think like 100 hours of education, 1,000 hours of clinical stuff, and then a board exam. But I think it was totally worth it. I'm a board member of these two organizations here. So the Society of OBGYN Hospitalists, and you can join as a student if you're interested in, and I'll share more about this later. But we are the society that represents OBGYN hospitalists in the United States, and we are moving to be a bit more international as well. And in that organization, I am the social media chair. And I also work on OB simulation. I love simulations. Maybe you've seen my most recent TikTok that went viral on birth simulation. I think I've scared many, many people, but but I love simulations. We use it to practice for emergencies, training others. I just love it. And then I'm also a board member of the Northwest Mothers Milk Bank, which we collect and process and distribute human donor milk for preterm and sick infants. And we're the only one in the Pacific Northwest. And I love that organization. I also do a lot of medical writing. I got started on Bundu, which is a pregnancy and parenting website that I love, and then Flow, which is an app, a menstrual tracker app, but it's also a lot more than that. And I write for these two organizations because they promote evidence-based information, and I'm very picky about where my stuff goes because I'm not about to write for Goop and Gwyneth Paltrow and all of her craziness. And it's super important when you are in medicine that you make sure that you protect your credentials and your reputation because you can't get that back. And media content creation on Instagram, TikTok, and YouTube, which I never thought I would do. I started about 2 years ago and it's just gone crazy. And I think a lot of it is because there's so much misinformation in women's health. So I use my accounts to combat that. And I've got a book coming out in September 2021 that is all based on that as well. It's all question based on women's health. And again, I found like my fun way to decompress. Like that's what I do for fun in my free time. And it's my way of writing and communicating and educating, which I love. So it's super fun. So all of this, like when I went to medical school, did you think I was thinking of any of it? No, I just like wanted to deliver babies. I didn't know any of this, but all of this just kind of snowballed and just kind of landed in my lap because of how I worked and what I was interested in. So there's so many things that you can, never say never. I don't know where I'll be in 10 or 20 years, but obviously I'm a doctor first. And when I'm at work, work is my work, but I get to do all these other extra little things that I never thought a medical degree would open up for me. And then in terms of my personal life, I already told you I'm married to a pediatrician. We've got two sons together, one who's going to be 10 next week, which is insane. And then a 5.5-year-old who's going on 15. So I drink a lot of coffee. I've been taking a lot of naps this pandemic. It's been great. I'm in the Pacific Northwest, so I love to hike and kayak. Kayaking is a great socially distanced sport right now. And I love to work out and read. So I keep those things for me. And if I don't do those things, then I'm not as good in my work life and vice versa. I need both parts of these. And if I worked full time, I wouldn't be able to do all this kind of stuff. And so you can have a personal life as a doctor. It's not just about working. I mean, yes, residency is hard. You work 80 hours a week some weeks, but that's not forever. It's time limited. And you can really shape your career. But no matter what stage of life, med school, residency, being an attending, you've got to keep parts of you for you. Otherwise, you can't be there for your patients. You have to pour from a full cup. As cheesy as it sounds, it's true. So why OBGYN? Because let's face it, the hours kind of suck. Although I think they're great because I think as a working mom, I love it because I can work nights and weekends when my husband is home. And so I think actually the flexibility is great, but babies come at all hours, they come on all holidays, they don't care. So for some people who are like, well, I want a nice lifestyle, maybe OBGYN isn't right for you, but here's why I love it. So when you think of OBGYN, you might think of, we get to do really fun stuff, right? We get to tell people they're pregnant and do ultrasounds. We get to deliver babies. That's my friend Bridget, who is currently working in New Orleans. We get to deliver these adorable babies. We get to be part of this amazing moment in people's lives. We get to do C-sections and we get to save people's lives, and that's really cool. We get to do surgery. We get to do laparoscopic surgery. We get to do open cases too, like hysterectomies, and have fun with that. We get to do contraceptive counseling and reproductive health counseling and appointments for that. We get to help these poor women through menopause, which I'm not looking forward to one day, but at least I'll be informed on how to deal with it. But it's more than that. It's dealing with these sorts of emergencies. So ovarian torsion, when an ovary twists on itself, and it's an emergency surgery if you want to save any ovarian tissue. We have to deal with emergencies like uterine ruptures, which you can see here. The uterus is opened up and the amniotic sac and the baby is protruding through. And if you didn't get this person to the operating room quickly, you could lose 1 or 2 lives. We have to tell people that they have ovarian cancer, which, as we know, we have no good screening tests in our current status, and can be deadly. We have to deal with lack of access or what's the word? Politically motivated restrictions and access to abortion, which is healthcare. And I'm not here to convince you of whether or not it is, but there are people who need pregnancies ended to save their lives. And then there are people who want to end their pregnancy for their own personal choices. And that can be really a really fulfilling part of your career. And it can also be a really hard part of your career. And then we have to deal with stillbirth and having a patient come in who hasn't felt her baby move in a day or two and ultrasound her and tell her that her baby has died. So when people think of OBGYN, we always talk about delivering babies and it's super fun, but it is the gamut and it is a huge spectrum of emotional issues, medical issues. And what's the hardest part, I think, is that when you've gone into the room and you've diagnosed the patient with a stillbirth and you have to tell her that, and then you have to run to the next room and deliver a couple's first baby. And it's this wonderful moment. And you can't carry what you had there into that other room. You have to be totally present in each room. And sometimes that's really hard and emotionally can be really hard. But you learn how to do it. And if you have a good team and a good support team, you figure out how to do it and not let it get to you. But it's a hard field. It's a beautiful field, but it can be a hard field. I happen to love all of it. I mean, I don't love the sad stuff, but I feel like I'm good at that, at being able to provide that care, and I take that on. And the people I work with are amazing at it too. So I feel like we provide that service. But it's not all just happy babies. You know, it's infertility. There's a lot. The good news is that with OBGYN, there are tons of options. So you can be a generalist, which means that you graduate your residency and you go out there and you work in the office, labor and delivery, you do a little bit of it all. Or you can choose to subspecialize, and these are some of the boarded subspecialties like GYN onc. You know, you can kind of read down the list here, and you can, and all of them, you know, they're all amazing. If you decide you maybe want to operate more, or you want to do more ultrasounds, or you're interested in critical care, you can kind of pick your pathway here. So there's boarded specialties, which means that they do a separate fellowship and they take board exams, and they're specialized in that as well. And that happens after residency. And then there's non-boarded subspecialties, which means that they might be like a 1-year program after residency, and you're not officially, you know, board certified, but you are recognized as being a subspecialist in these areas. One that I think is great is MIGS, or minimally invasive GYN surgery. So that's a year, it's a year fellowship. And so these are people who, you know, you go to OBGYN and you just want to do GYN, and you just want to do laparoscopic surgery and really challenging surgeries. Like, this is a great field for you. So let's talk about how to get there. So the path to OBGYN starts with medical school, and in your 4th year, you should do what's called a sub-internship. In your in OBGYN. So basically that's when you act, or it might be called an AI or an acting internship. So you've done your basic OBGYN rotation, and this is more of an advanced one. And the purpose of this is that you're given the responsibilities like an intern, but you're not an intern. And it's your chance to just show off and show that you're awesome and get awesome letters of recommendation. It's also your chance to prove that you can do this, and then to prove to yourself that you want to do that. And like I said, you can do more electives in your 4th year of medical school if you want. And it's not that they're bad, but understand that if you're going into residency, you're going to get a lot of that. So try and be more broad in your medical education, and maybe, you know, try to use that elective time for other stuff that might help complement your eventual OBGYN residency. So maybe it's working in the ICU, or it's doing some general surgery rotations so that you get more time in the operating room. And then you do residency for 4 years. We'll see if that changes. And in residency, you get a broad training in OB and GYN office practice. And I'll show you what a typical residency schedule will look like here in just a moment. And then you graduate, and right when you graduate, you take your written boards, which are just like they sound, they're a written test. You take that right away, and you figure out if you pass or not. And then you go out and you practice for a year. And that's kind of like your free pass year. And then your 2nd year in practice, you collect cases. So any patient that you've seen in the office, any surgeries, you collect your cases. And there's this whole convoluted method, but the long and the short of it is that you end up submitting a whole list of all your cases, very specific. Thanks, American College of OBGYN. And then you submit that, and then you get a board date, and you fly to Dallas. If you ever want to scare an OBGYN, just say the word Dallas, because we all like have a little seizure. And that's where you go and you have your oral exams. And that's where you sit in a room, and over 3 hours, you are basically grilled about your cases by 2 examiners in each hour session. So 2 in OBGYN, 2 in obstetrics, 2 in GYN, and 2 in office practice. And the purpose of this is that you can explain what you did. You can convince these people, who are very well qualified OBGYNs, that you are safe in practice and you are following standards of care. And then you pass that, and you're fully board certified. So it's a process. And it doesn't end there. If you do want to do subspecialties, like I said, you'll do that separate training, and then you'll take separate board exams. And it's not over, because you need to keep learning. And so you take your maintenance of certification. You do maintenance of certification yearly. So every year we're required to read articles and submit answers to questions to prove that we are staying current, which I think is appropriate because medicine changes. And so this is an example of a schedule. This is actually my residency, although that's what they're doing now. It's different than when I was there. So each year, as you move through, you get more and more responsibility. You can see that in the earlier years, you're doing a lot more labor and delivery, and then you're doing a lot more GYN in the later years. And throughout this, you've got REI, which stands for reproductive endocrinology and infertility. Antepartum is managing high-risk hospitalized pregnant patients. Family planning is learning how to do terminations and birth control and that kind of thing. and all sorts of different kind of stuff. So they're pretty much the same everywhere. But the whole point of it is that by the time you finish residency, you've got this broad training in all of these, and you are qualified to treat a broad array of generalized things that the generalist OBGYN would see. So I want to show you what a quick day in the life is, with the moment of truth being that there's no typical day in the life for an OBGYN. So if you're in clinic one day, if you've got patients in the hospital, maybe you rounded on the day before, or maybe you delivered one the day before and you want to go see her. You'll go see them before your clinic starts. And then you'll have clinics scheduled from 8 to 5. And this is just a small example of the kinds of things that you would see in a typical clinic day. And what I think is really great about OBGYN is that it's all different stuff. So you might be seeing pregnant patients, you might be seeing those for annual exams or birth control counseling. Somebody might come in and just found out their partner cheated on them and they need STI testing. You get to do some procedures like putting in IUDs or Nexplanons, endometrial biopsies. I mean, this is just a very small smattering of what we do. But it's fun. It's a nice mix of procedures and then just your regular clinic visits. And then you just you're doing your charting before, during, after. Meanwhile, you're getting paged or answering things from your in basket, which is just kind of messages from your electronic medical record. You're following up labs on patients that you've seen the day before. You're coordinating care, referrals, that kind of thing. So that's a typical clinic day. An OR, or an operating room day, is kind of like what it sounds like. So you might have a day a week scheduled where you've got patients on your OR schedule. So the night before, you prep your patients. So you read through, make sure they've got their history and physicals on a chart. So when they come in, the nurse isn't paging you at 6 a.m. and saying, your patient's here, but you don't have orders. You're reading up if you've got complicated cases. You might read through them before just to remind yourself of the steps. It doesn't matter how many times you've done something. You always want to run it through in your head. You want to make sure their labs are in, they're cleared. Nowadays, you want to make sure their COVID testing is negative. And then you might operate and you might do some minor cases. And when we say minor, we mean cases that are shorter and the patients go home the same day. So it might be like a hysteroscopy where you're putting a camera in the uterus to see a polyp and take it out, or a tubal ligation or a DNC for heavy bleeding. Or you might do major cases like a hysterectomy or removal of the uterus, or a myomectomy, which is a removal of fibroids. And there's lots of other surgeries there, but that's just kind of our most common ones. In between cases, when your patient's getting rolled to the recovery room, you're going to see your next one. You're also post-op checking your patients from beforehand. So it's just, OR days are great because they kind of move kind of quickly. And then before you go home at night, or in the afternoon, go see your patients, do afternoon checks on the ones that are getting admitted, and then go home, and then you'll round on them afterwards. Or the next days till they go home. This is what a typical labor and delivery day or night looks like. So this is what I do. This is all that I do. And so for us, these are 12-hour shifts. At some places, they're 24-hour shifts. I don't see the benefit of 24-hour shifts in this day and age because we know the longer you're awake, the more likely you are to make mistakes. So I just think it's ridiculous. So we'll work 7 to 9 a.m. or p.m. We'll come in, we'll sign out. Like, for example, for a day shift, we'll sign out with the offgoing night team and the oncoming MFM, which is the maternal fetal medicine specialist, or the high risk OB. And we work as an OB hospitals very closely with them. So we'll just cover any issues that happened overnight and divide up who's going to see who on the floor that day. We'll round on patients, which means that we go in and we see them, we talk to them, we make plans for the day. We meet any laboring patients that might have been in the night before. See patients that come into triage. So what I like about OBGYN is that labor and delivery triage is basically an emergency room for labor and delivery. So unless they've got like a gunshot wound or they're having an acute stroke or a heart attack, they come to labor and delivery first. If those other things are going on, I will happily come down to the emergency room and meet them there, but anything else. So it's not just coming in because they're in labor. It's if they've got kidney stones, if they've got headaches, if they've got fevers now and COVID, we will see all of that. So it's a very broad, it's basically an emergency room. If there are scheduled C-sections, we'll do those, or we'll help with any emergencies. We are really the specialists when it comes to emergencies as OB hospitalists, because we only work in the hospital. So we're the ones that people call when something goes wrong, either to assist, or if that OBGYN might be in the office seeing patients, they can't get to labor and delivery quick enough if they've got somebody in labor. So we're the ones that deal with hemorrhages, shoulder dystocias, fetal heart rate decelerations where the babies are looking bad, and they need to have an emergency C-section. We kind of do all of that. We'll admit new patients, we'll discharge patients. We do a whole lot of stuff. So this is kind of my plug for being an OB hospitalist. So that's myself and 3 other OB hospitalists were filming for our conference that we had in September. Normally we have a conference every year in person, but this year was virtual sim, actually. And so we really function as unit leaders. So one of the things we do is we do simulations for our unit. We help to participate in research studies. We teach others. We're really basically like the experts on the unit. So private practice OBGYNs, they'll come to us and say, hey, what about this? What about this protocol in treating hypertension? We're kind of seen as the go-tos. And so if you're interested, SOGH is an awesome organization and you can totally join as a student if you're interested. So who does well in OBGYN? Somebody who likes fast-paced work, because like I said, babies don't always behave and they don't always read the textbooks, and sometimes they decide to be naughty and you got to, take them to the OR quickly or do something quickly. I love it because I love that adrenaline rush. People who tend to like OBGYN, they also tend to like emergency medicine, those kind of things. But what I like is the more focused nature of what I do rather than just the broad scope of emergency medicine. Bodily fluids cannot scare you. I hate vomit, but thankfully that's not the main end that I'm at, but you can deal with blood and amniotic fluid and that kind of thing. You're okay with unpredictability. So I'm okay with unpredictability in my 12-hour shift because I know no matter what, I can do anything for 12 hours. But at the end of the day, I know that I get to go home and my pager is off. And for me, that works. That's not for everybody, but I do enjoy that. And I know that every day is different. I don't mind being awake at night, and probably I don't mind it so much because I'm part-time. If I had to just do night shifts, I'd probably go crazy, but I don't mind the mix. I do enjoy a combination of medicine and surgery. If I just was in the OR all day, I would not like that. And if I never got to be in the OR, I would not like that. And obstetrics and gynecology is the perfect mix for me. And you really need to be able to communicate well, especially with sensitive topics, and have a really good bedside manner because the stuff that we deal with can be really personal and intimate, and you have to be comfortable saying the word vagina a lot. It's not all roses. And I think it's really important when you are following people online or elsewhere to understand that if somebody says that something totally sucks all the time or something's amazing all the time, both of those people are probably hallucinating and wrong. It's somewhere in the middle, like there are pluses and minuses. And I think it's important to follow people who give you a realistic picture. So what I love about OBGYN, my patients are usually healthy. I'm not dealing with 90-year-olds all day or people have chronic problems that I can't fix. You get to deliver babies. I mean, that is freaking awesome. It is so much fun. And it's a super flexible field. You can change what you want to do in different life phases. So maybe you want to be a generalist OBGYN who does a mix of office practice and labor and delivery and OR stuff. And then maybe when you hit 35 or 40 or 45, you're like, that's getting old. I just want to do hospitalist work, or I just want to do GYN. And you can change it up. And it's really nice to be able to have that flexibility. And for me, I really love the advocacy work that it meshes well with, and being able to advocate as a women's healthcare ally. I enjoy that. There are cons, and I will not lie, malpractice. I believe we have the highest malpractices out of all the specialties. And it's because in this country, or well, just because in general, our patients are supposed to do well, right? They're supposed to be young and healthy. Women are not supposed to die in childbirth. Babies are all supposed to be born perfect. Now, I know that's not the case. Things happen and we can't prevent all of it. But in this country, sometimes it's, for me, it's not a matter of if I will ever get sued, it's a matter of when I will get sued. So I just kind of see it that way. But I don't sit there and let that really bother me too much because there's only so much I can control. I'm hospital employed. They pay my malpractice. It was part of, I'm aware of it, but I don't let it get me down. The hours can be kind of a downfall, especially if you are a generalist OBGYN and you're always on call for your patients. There's that lack of that predictable schedule. This is not, I don't know, it's not plastic surgery, it's not radiology, it's not pathology. When, certain things, you can choose not to work weekends if you're just an outpatient provider. But again, for me, that's kind of a plus. And reimbursement for OB is not great. That's a whole talk in and of itself. But I mean, again, I think we're paid just fine. But, we might do a surgery and a plastic surgeon might do a surgery, and what they get reimbursed is very different. So it's just a different field. And sometimes we aren't seen as full surgeons, which I find hilarious when sometimes other general surgeons will make jokes about OBGYNs, yet when it's their wife that comes in labor and they have an acute hemorrhage and they need that baby out by C-section in less than a minute, and I'm the one who does it, then all of a sudden they respect us. But, you just have to be okay with, Sometimes surgeons will joke about us, but yet they always call us whenever they have to deal with the vagina. So it's all good. And it can be hard on the emotions, obviously, the hard stuff that we deal with. So I don't want to go over too much. I've got 2 cases here, and you can let me know, or you can just kind of give me a heads up when to stop. I think I'm going to go quickly through this one because it's a bit more medical based, and I just want to give you a flavor, but I don't want to bog you guys down in like the nitty gritty of what we're talking about here, because the point here is not to teach you about what I'm about to teach you about, but just to give you an idea of what it looks like. So we'll go kind of quickly through this one. So we have patient PIH, and I'll get into later why I chose those initials, but she comes in, let me move the screen here so I can actually see the words that I wrote. She comes in, and these are the abbreviations that we use. So 18-year-old G1, so the G stands for gravida, so it means it's her first baby, at 39 weeks, 4 days gestational age. So that's just how far along she is. So a full-term pregnancy or a due date is 40 weeks, 0 days, which again is only an estimation. And we put her on the monitor here, and that top squiggles there, that is the fetal heart rate. And you can see in the blue, that's where we want the baseline to be. And so her baseline's in about the 150s with those nice, what we call accelerations. So when the baby moves, his or her heart rate goes up, it tells us that the baby is well oxygenated. And the bottom, those little hills, that is the monitor on her uterus, or what we call the tocometry. And each little hill is a contraction. So she presents to labor and delivery with a headache. And her blood pressure here is 162/102 and 170/98. And you don't need to be a doctor to know that those numbers are too high. So you notice that. And her urine protein dips 3+ protein. It means there's a lot of protein she's spilling in her urine. And we'll get to why that's important. And so what do you do first? You could either treat her headache, you could treat her blood pressure, or you could check her cervix, because as you saw here, she's contracting. Maybe she's in labor. And I can't see the comments right now, but you guys can take some guesses of which one you might do. But if you were with me, this is what we would do. We would treat her blood pressure, because she is in a blood pressure range where she could have a stroke. And so high blood pressure in pregnancy is something we see really commonly. And the American College of OBGYN puts out these practice bulletins, which are like our guidelines. And this is one, I swear to God, they change it and they update it every 10 minutes, it feels like. But it's an evolving picture of how we define gestational hypertension, or hypertension in pregnancy. Also used to be called pregnancy-induced hypertension, or PIH, and preeclampsia, which is hypertension plus some other things in pregnancy. And this can be a really great resource if you have a patient like patient PIH who walks onto the floor. And so high blood pressure in pregnancy, you can have a few different flavors. You can have chronic hypertension, which means that she had it before pregnancy. You can have gestational hypertension, which means hypertension in pregnancy, and it can either be severe or not severe. Or you can have preeclampsia, again, severe or not severe. And I'm not going to get into all the nitty gritty of this, but I will tell you that it's very important to be able to differentiate if something is mild or severe, whether it's gestational or preeclampsia, because that determines whether or not you will manage them expectantly, which means that you'll keep her pregnant, or you'll deliver her, because the only cure for either of these is delivery. And if you can see here, with gestational hypertension on the left, you can see what qualifies as the readings for ruling in for either severe or non-severe. And about half of these will go on to deliver preeclampsia, which is what we've got on the right, which is the blood pressure stuff plus these other things. So proteinuria, or you're spilling protein in your urine, and that tells us that your kidneys are having an issue. And then some other things like thrombocytopenia, which means low platelets, and elevated creatinine, which is another marker of kidney dysfunction, abnormal liver function tests, or pulmonary edema. So these are all clinical pictures of preeclampsia, and also a new onset headache. Does that sound familiar? Or visual disturbances, which represents some neurologic compromise in the brain. And why does it matter? It matters because preeclampsia, and gestational hypertension, I should say too, complicates up to about 8% of pregnancies. So I deal with this every day. And it can lead to maternal death. And it is shocking how many women will die of this worldwide because they do not get diagnosed or treated. Thankfully, in the US, it's not our #1 cause of death here, but it's still definitely a huge issue with maternal morbidity, and unfortunately, in some cases, mortality. So our patient, we treat her with IV blood pressure medications because we want to get her blood pressure down quickly. And we send off some labs. And again, I'm not here to test you on, on knowing lab values, but I can tell you these are not normal. So these are liver function tests, the AST and the ALT. They're 3 times normal. Her platelets, they should be above 140,000. Hers are 90,000. And her creatinine is 1, and it should be less than 0.8. So everything's going all sorts of crazy in her body right now. And then she says, "Doctor, I just don't feel right. My head is killing me." And you're like, "Well, what's going on? I treated your blood pressure." And moments later, she has a seizure, which there was a video, but I wasn't able to pull it in. So she has what we call a tonic-clonic or an eclamptic seizure. And her baby starts to look like this. And you can see on the left, those first couple minutes, that baseline's in like the 130s, and that's awesome. And then it drops down into the 60s. Now, that's a normal heart rate for me and you. That can lead to the death of a baby if that's prolonged. But what we learn in OBGYN residency, and it's so hard, when a mom's having a seizure, you don't look at the fetal heart rate tracing. The reason it looks like that is because that placenta is not getting oxygen while she's getting a seizure. But if you treat her seizure, her baby will look better. In every other obstetric emergency, if a baby looks like that, you're running to the OR and you're getting that baby out in a few minutes. But with eclampsia, it's a different flavor. And I don't care how experienced you are, listening to that slow heartbeat, like you almost have to turn the monitor off. And it's really hard to sit there and take it while you're managing her eclampsia. And this is how you manage it. So ABC is airway, breathing, circulation. You do that left lateral tilt. And if you can see the picture in the middle there, it's because if you see the inferior vena cava and the aorta, if she's flat on her back, the uterus is compressing it. If you put her on her side, that helps to get the uterus off of those vessels and helps her circulate more. You're going to give her oxygen, safety precautions, so seizure precautions, you put bed rails up. Give magnesium sulfate, which has been shown to help prevent recurrent seizures. It's one of the best treatments that we have in eclampsia. And move towards delivery. Doesn't mean an emergent delivery, but it means you've just declared yourself as having severe preeclampsia, and now it's time to get delivered. So this is what you do. You start magnesium sulfate, you induce her labor, control her blood pressures, and she goes on to deliver a healthy baby girl who weighs 5 pounds. That's really tiny for a full-term pregnancy. And the reason she's so small is that placenta in preeclampsia is not normal. And so you can see in a healthy pregnancy on the left, you see that this is really, simplified, but the spiral arteries, which are the blood vessels from the placenta that go into the wall of the uterus, they're nice and healthy in that left, in a regular healthy pregnancy. But in preeclampsia, they're not normal. And so this is why we have issues with blood pressure. This is why babies can be really small. This is why they're more prone to have things like placental abruption. So yeah, so that's a typical day on my labor and delivery unit. I'm going to run through this one real quick, and then I'm going to be done and we can ask questions. So here's somebody who's on your schedule today, this teen. She looks so excited to see you. So she comes in, her name's Jane, and she's a 16-year-old who came into clinic with her mom. And her mom says that she's here to talk about Jane's heavy periods. She doesn't have any concerning medical history or surgical history. And mom answers most questions for Jane because Jane is like so embarrassed to be there right now. She's like, "Oh my God, mom, I don't want to be here." And again, I can't see the chat room, but you guys can weigh in if you think, should you ask mom to leave the room at any point? And then what do you do if you're like, mom, all my teenage patients I see at some point alone. I'd like you to, step out in the waiting room and then we'll bring you back in. What if she refuses? It can be the whole thing. But the long and the short of it is that yes, you should, because anytime, you can pick when, in your practice, anybody over the age of 13, you make sure that you're always going to interview them alone for at least a little bit because they deserve that right to confidentiality and the ability to talk to you directly. They're old enough to do that. So if you make it a standard, then even your MA, when they're rooming the patient, can say, "Hey, Dr. Lincoln, just so you know, she interviews all her patients alone at some point, mom." So she can kind of mentally wrap her head around that so that when you ask her to leave, she doesn't lose it. So you send mom to the waiting room and you interview Jane. And Jane was like, "Actually, I'm having sex with my boyfriend. My mom doesn't know, and I need birth control. And I would tell you, my mom, it's because I have heavy periods, but they're actually fine." Well, now what? Because now things just got spicy. And like, now you've got to deal with this. And how are you going to chart this? And what's your role? And do you have to tell her mom? And blah, blah, blah. And this might feel really uncomfortable for you. And this is like just another Tuesday for an OBGYN. So I think it's important to step back and always keep this in your head. First, do no harm, which is part of the oath that we take when we get our white coats and when we graduate medical school. So who's your patient and who do you need to protect? So here's your considerations. You've got your ethical considerations to your patient, but then also to her mom, right? She's a minor. You've got the medical considerations. Oh my God, Jane needs birth control. She needs STI testing. Need to screen for IPV, which is intimate partner violence. And then you've got to think about the legal considerations. What are you allowed to do in your state? And guess what? You've got 20 minutes on your schedule for this. Welcome to American medicine. how are you going to do it all? So one resource that I love and I use all the time is the Guttmacher Institute, which is a really strange name, but this is one to bookmark. And what I love is that you can go to this and you can see specific laws for each state, and they update this like every week. So if you're curious about what you can do in your state when it comes to reproductive health services or what minors have access to, you can go to this website. And so let's say you do it, and Jane's right there, and then you look it up, and you're like, okay, so what am I in terms of what she can consent to? Like, can she consent to STI testing? And so you can find your state and you can see, what she's allowed to do. And you might imagine some states, especially the ones in the South, are really bad at allowing some of this, but not all. And then you go here. Okay, she wants contraception. Am I allowed to do that? She wants STI services. Do I have to tell her? I mean, there's some, if you look in, you can't see it here, but if you go all the way to the bottom of the table, some of those asterisks mean that you're allowed to tell her mom that you started her on birth control if you think it's in the best interest of the patient, but you don't have to. It's important to know the laws in your state. And so you end up deciding that you're going to counsel her on her options. And the CDC has a really great infographic here about the most effective to the least effective options. And so you decide that you're going to start her on some birth control. You decide that you're going to code for this as menorrhagia management, which means management of heavy periods, as opposed to contraceptive counseling, because this is going to show up on her mom's insurance. You do discuss screening for things like gonorrhea, chlamydia, HIV. Jane is really worried that it's going to show up on her mom's insurance, but you do have the number of a local county clinic that will do it at a very cheap or sliding scale cost that she can pay cash, so it doesn't show up on her insurance. She doesn't need a pelvic exam today, and now Jane loves you because you don't need a pelvic exam to start birth control for most of them. You provide her with condoms because it doesn't matter what birth control, you talk to her about the fact that you need to prevent against STIs. You do make sure that the sex is consensual, it's not forced, and she says that it is. And you make a note in your chart, and you've got some, because everything's electronic and parents can have access. Maybe you put a little symbol or something that tells you, oh yeah, we had this conversation that I didn't want to share with her mother because it's in the best interest of the patient, and I keep separate written chart notes elsewhere that her parents don't have access to. But throughout all this, it's not about hiding things. You say, you know what, Jane, it really would be great if you could talk to your parents about this, because who knows what can happen, and you might be surprised and they might want to know. But you're also a realist and you're not going to force that. And you offer to be like, hey, do you want to have the conversation here with me right now? Because those conversations actually can go really well. And then what was the last one here? Oh yeah, and then we talk about emergency contraception and how to get it. So all of this in 20 minutes. And the first time you do this, it might feel like, oh my God. But I want you to understand that being an OBGYN, yes, there's a lot of medical stuff, but there's all this other stuff too. And I enjoy that. If you don't, you might not want to go into this field, but I enjoy feeling that this girl who maybe is just sexually active, doesn't know what she's doing, now feels that she's off on a safe foot. She's got a doctor she can trust, she can confide in, she feels heard, and now she's going to be safer because of you. So OBGYN can be really messy, literally and figuratively. But it's also amazing. And I love the opportunity that I have to interact with my patients. And every day that I go to work, I am so thankful. And when people say, what would you do if you couldn't do medicine? I don't know, because this is truly the only thing that I love doing. So I love it. I would love to stop here and take questions. I do want to highlight that ACOG, the American College of OBGYN, does have a medical students page if you're interested in that. And you can join, I think as a med student, I think you can join pre-med too. But if you want to go there, they've got a lot of good information there. And with that, that's all I've got. I don't know if you want me to stop sharing my screen or how we should do that, but that's it.
If you want to, I'm sorry. If you want to unshare your screen, you totally can. It's up to you.
Sure. Yeah.
But right now, I just want to thank you for all your wonderful information. And then we are going to go into some questions that
Sure.
were left in the chat. There are a ton. So our first one will be, what was your experience like having a child while you were doing residency?
It was hard. It was really hard. But I will tell you, I think that you just decide what time is right for you. I do not think there's a perfect time. And I know people who have done it successfully as medical students, as residents, as attendings. I've had one in residency and one as an attending, and both had their pluses and minuses. And for us, we just decided it was the right time. It was hard. I had to go back after 6 weeks of maternity leave, and I had to make up 2 of those weeks. And it was really hard to be separated from my baby for 24 hours at a time when I was on call. But at the same time, I don't know. I mean, it still worked out, and it still was the best time for us. So I think the important thing is to lower the bar Don't try to be a perfect parent, and have help, whatever that help is for you. For us, we had a nanny and she was amazing. And just know that it's okay to ask for help. And I also had a really supportive workplace too. And you can get that vibe when you're interviewing somewhere if they're going to be supportive or not. And they should be, because for the love of God, like, we help women deliver babies every day. Like, we should be supporting our own colleagues. But I was at a really supportive program. So, but that's a great question.
Thank you. You've mentioned imposter syndrome during your talk.
Mhm.
How do you deal with imposter syndrome?
I don't know, because you guys are like, hey, there's 200 people here today. And I'm like, I hope that I can give them something useful. I think that you just need to have that internal monologue of, you are good enough and you are here, and stop the comparison game, because you're always going to find somebody who is smarter than you. So for me, when I'm feeling doubtful in those moments, whether it was in medical school or residency, or even in the middle of a postpartum hemorrhage, when I'm standing there, oh my God, you think back, you're like, I've got this, I've got the training, I can do this. And then the more that you do it, it becomes a self-fulfilling prophecy. Um, I just think it's really important not to play the comparison game, and understand that if you've made it to medical school and residency, you are smart enough, you're good enough for this, you can do it.
Thank you. So our
Mhm.
next question is going to be like a two-part question.
Mhm.
It is, why do you think the mortality
Mhm.
rate is so high in America? And
Mhm.
then, do you get punished if someone dies during childbirth?
Mhm. So I think the mortality rate, so background for people who don't know, we have one of the highest mortality rates in a developed country. And in some ways it's going up, and it's very racially based too. So we know that women of color um, are much more likely to have complications of childbirth and postpartum. Still rare, but it's still there. I don't want to scare people out of having babies. I think a lot of it has to do with lack of access to care. It starts right there. That we know that it's really hard to get good health care in this country. Um, think about trying to access health, insurance, trying to even make a call into a clinic, and trying to get a referral. It can be really hard. Whereas other countries that have single payer systems, it's much more streamlined for essential care. And I think that's a big part of it. And do you get punished? I mean, if you have a complication, whether it's the loss of a mother or a baby or a surgical complication, there's always the chance that you could get sued. Um, and sometimes these things are completely unavoidable, and sometimes they're not, and that's appropriate. Um, if you've had a hard outcome, your hospital will review it. So it'll go through a review of, and it's not to punish you, but it's to figure out, it's to do a root cause analysis to figure out, was this preventable? And if it was, what could we have done along the way? And what can we do to learn from this? And what can we do in the future? So it's not punitive, but it's to prevent it from happening again. Um, and those can be really hard, because sometimes you're like, I did everything right and still this happened. That can be really hard, especially in obstetrics, when you think every baby is supposed to be born perfectly and healthy, and it can be really hard. And I think I should highlight, and maybe this, you might be like, oh my gosh, why is she talking about this? But the suicide rate is much higher. It's really high for physicians. And I think part of it is that because we have some crazy jobs, we do some crazy stuff. But I think too is that up until really now, people have just expected us to just keep on going and put a smile on. I think it's totally okay to say that a lot of us have or do go to therapy and we talk to people, because what we do is really abnormal, dealing with death every day. Um, but doing that can help you work through it, and can help you get to a point where you're like, this happened, it was not my fault, or it was, and here's how I'm not going to do it again. I think that's really important to know that we are not perfect.
Thank you. The next question in the
Yeah.
chat is, how did COVID change your current practice?
Oh, COVID. It's really hard. It is really, it has changed our current practice. So specifically in obstetrics and gynecology, the best thing about our field is that we help people build families. And right now we can't have those families in the hospital. I miss the little siblings that would come through and meet their baby brothers and sisters. I miss being able to hug a patient. It's really hard to tell somebody that their baby has no heartbeat when you've got all this gear on and you feel like that physical barrier between you two. Like, our field is not meant to be 6 feet apart. And that's really hard. I think it's hard knowing that pregnant people are going in to get ultrasounds, and their partners can't come in. It's hard. The hardest thing for all physicians though right now is that we are dealing with a public who doesn't understand that they need to stay home, and that when they do this and they don't, and they go out and they flaunt, they flout it and they show it off, it's a slap in the face, because you're saying that you just don't care about the fact that, like, I'm exposing my family every day. It's really hard. And it's just stressful. There's going to be so much trauma and PTSD that's going to last for years, especially in healthcare providers. I personally feel like I'm dealing with it okay, because I'm in a place where I feel like I'm very well supported. I also really enjoy being married to somebody in medicine, because I can talk to him about this. Not everybody wants that. They want to just leave it at work. For me, it helps because I know that my partner understands. Um, and I mean, but I'm struggling. I mean, I usually love Christmas. I have like no Christmas spirit this year, but I'm trying. You fake it till you make it, and you find the things that you enjoy. Like, I love this is super fun for me, being able to talk to people. And we'll get through it. We'll be okay. I mean, again, I've gone through stuff. I've been through a hurricane. It ends. It will end. And when you're in the midst of it, it can be hard. I will say the nice thing about being a doctor right now is that everybody who's stuck at home, like the original quarantine, at least I got to go out. So yeah, maybe I was being exposed to COVID, but God, at least I got to hang out with some nurses, and we got to have some conversations, and I could eat in the cafeteria. It was nice to get out of my house, but that's just sort of my sick and twisted humor of like, well, hey, there's a silver lining to this pandemic. So, but it will end. We'll get through it.
Thank you.
Mhm.
So our next question is going to be more about your specialty.
Mhm.
So what are some other specialties you considered, and what ultimately made you decide to go into
Mhm.
OBGYN?
I know. I wish I could tell you that I considered some other specialties, but I didn't really. I mean, for my first year of med school, I got to shadow an OBGYN, and I was kind of hooked. Um, I would say within OBGYN for a while, I thought I wanted to do maternal fetal medicine, which was high risk pregnancy, because I really liked the complicated stuff. But I am not super spatial. And so having to do ultrasound every day, I would suck at it. But now I'm an OB hospitalist, and I get to manage all those patients along with the high risk OBGYN doctors. So I feel like I found my niche. I don't know what I would, I really, I don't know what other field I would have done. So I'm glad it worked out.
Thank you. And the next
Yeah.
question is, have you ever had to deliver a baby not in a hospital setting, like in a
Oh,
car?
that's so funny. You should ask. I think I'm allowed to say this. Yeah, I delivered my neighbor. Was having her third baby, and she just didn't make it in time. And I thought it was a joke because it was her due date, and I thought they were pranking me, and they were not. Um, so I ran over there and delivered her baby, and then the baby wasn't doing so hot, so I sent the husband over to my house to get my husband, who is a pediatrician, and we joked that it was the best well-attended accidental home birth in the history of home births. And they gave the baby the middle name Lincoln, which we thought was really sweet. And yeah, that was kind of crazy. Other than that, no, that's my only out of hospital birth so far. Knock on wood.
I love that. That must have
Yeah.
been so crazy and an adrenaline rush for you.
Yeah. So adrenaline rush, yes, perfect example. Yeah, it became kind of the talk of the block for a while. It's kind of fun.
Okay, so our next question will be, do you have any tips on how to get recommendation letters during COVID?
Yeah. How to get recommendation letters during COVID. Yeah, I think that God, you guys are probably better well versed at this than I am. I think it's important to keep reaching out to see what opportunities are available for in-person shadowing and that sort of thing, because different places are, they're changing their rules. If you're able to get into things like, a job or a position where you're able to work in a hospital or clinic, such as a scribe, um, then you can do it that way, and the people you work with. I think that it's limited right now, but it doesn't mean that you can't connect in a different way. So maybe reaching out to somebody and saying, "Hey, I am, I'm pre-med. I can't volunteer in the hospital or the clinic. What do you need me to do from a research standpoint? Like, what can I do for you? Like, are there any outstanding research projects, things that I can do from home?" You'd be surprised how much stuff is out there. Um, and then getting a letter of recommendation from that, or saying, "Hey, I can't shadow you in person, but I would love it. Would it be okay if I you sent me a case and I looked into it and we discussed it once a week, and then that person could speak to your ability to synthesize. There's just lots of different creative ways that you can do it. And your letters of recommendation don't have to come from physicians. So maybe you're like, you guys setting this up, or you set up a volunteer organization, or you set up a peer-to-peer thing. I mean, you can then get letters of recommendation from the people you're working with. So it doesn't just have to be about being in the hospital or in the office. And you guys are more creative. You'll come up with better ideas.
Thank you. Do you work in a group
Yeah.
setting in the hospital, like with PAs, nurses? And can you talk about that dynamic?
Yeah, so in my hospital, my partners, other OB hospitalists, I think there are 7 or 8 of us, and there's only one on at a time. But who I work with directly are the high-risk OBGYN doctor and delivers. They're private practitioners who deliver in the hospital. We have certified nurse midwives who deliver in the hospital, and we back some of them up, and that's super fun. We don't have any physician's assistants in inpatient, but outpatient you can, and there can also be nurse practitioners who work in outpatient, women's health nurse practitioners. Yeah, I don't know. We're kind of we all work together, we all pitch in, and I think that's just the way that OBGYN works, because we all know that things can just change in an instant. Babies can fly out in an instant, people can hemorrhage in an instant. So we all work really well together. And I love that, because I feel like I can always bounce other ideas off of other people. I love working with the nurse midwives because I feel that they're appropriate for the majority of low risk women, and they can do that and do the birth stuff and let me manage the hypertension and the hemorrhage. And that way we can kind of each work to the top of our training. And it's super fun. Yeah, it's a fun team sport.
Great. So our next question is about your relationship with your husband. It's because of HIPAA, how detailed are you allowed to speak with your husband?
Yeah, it's funny because he just walked by and put our kiddos to bed. Yeah, I mean, we don't share details because it's, I mean, we don't share patient names or that sort of thing unless we're sharing a patient. Sometimes we do, and that's super fun. But yeah, I mean, we're not super detailed because you just want to be respectful of patient privacy. And I mean, it's probably like this everywhere, but I feel like Portland, it's a small world. So yeah, we tend to keep things pretty general. But that's a good question.
Thank you. The next question is, can you talk more about being an IBCLC or how that has helped you in being an OBGYN?
Yeah, so again, IBCLC stands for International Board Certified Lactation Consultant, and it has helped me immensely because I'm hoping this is changing, but in OBGYN residency, we don't get a ton of training on the management of breastfeeding, which might sound really stupid, and it is, because just because the baby comes out, we're not done. And our patients need us. And so I wanted more education. After I finished residency in Portland, I worked for 3 years in northeastern Pennsylvania. Breastfeeding rates were very different in both places. And where I was in Pennsylvania, they were terrible. And I felt like I wanted to help these women, but I didn't have all the information I needed to. So that's when I decided to get my training. And I love it because, instead of saying, well, the lactation consultant will come and help you, I can help them. And when physicians help other women breastfeed, they are more likely to continue to breastfeed than if they were to refer them to somebody else. And it's stupid, but it's just that patients tend to, if you've got MD or DO after your name, they tend to think that what you're saying is more important, which I think is totally stupid, but they do. And so if what I'm saying rings with them a little more true and helps them get on board, then that's awesome. And I also think it's fun because it's opened up that whole medical director position that I've been doing at the postpartum clinic. So it's another way that I'm able to use my medical degree in a completely different way.
Thank you.
Yeah.
So our next question is going to be on what are your thoughts about male OBGYN?
I think they're great. I think that, I had male co-residents in my class. A bunch of my attendings were male. I mean, we joke that they're like honorary women by the time they're done because they're so well versed. I mean, I think it's like you wouldn't say that somebody had to have cancer to be a cancer doctor. Somebody doesn't have to have diabetes to be an endocrinologist. So why do you have to have a vagina to be an OBGYN? Yeah, maybe it helps you understand some things a little more intimately, but I will tell you that, again, do you have to have had babies to be a good obstetrician? I don't think so. And sometimes I think my male partners are slightly more understanding than me. I'm like, well, I worked up until 40 weeks of pregnancy, like they're sometimes they're like, Jen, and I'm joking, we're not all like that, but I think that there's absolutely a role. And I think that to just exclude an entire gender out of a field, you're missing out on their different perspective and their what they have to add is valuable. So I think, pick whoever you want to go see, we're comfortable with, but understand that, men make fantastic OBGYNs too.
The next question is, how did you deal with stress and time management before and during med school and just in general right now?
So I'm not a big spender, but I do buy really good coffee. So that is sort of my that is my stress management. I wake up in the morning, I know I've got a good cup of coffee to look forward to, and then I treat myself in the afternoon. For me, it's just about knowing when to walk away. So this afternoon, for an example, I had so much work I need to do, and I still do. And I was starting to get super overwhelmed by it, and I could have just pushed through and end up exhausted and end up angry. And I just decided to take a nap because you just got to listen to your body. So for me, and you know what, tomorrow's another day, it'll be there. I'm very much a list-oriented person, a goal-oriented person. Ask my husband, I've got my whole week planned, I've got my whole day planned. And for me, that works for me. Doesn't work for everybody. So I'm able to see where I need to do things. And then, but I'm also flexible. If I'm not feeling it, I know that I can wait. And I have my outlets. So, it's hiking, it's Netflix, it's reading books, it's talking to my friends. Because if you don't keep those things, then you're just gonna bottom out and you're not gonna be good to anybody. Yeah, those are my main things. But yeah, good coffee, which is probably too much of my budget goes to that.
Totally understand that. Okay, so our next question is going to be about, can you speak a little bit more about how Catholic school impacted your future as an OBGYN?
Oh yeah. So in my book, I address this, and I talk about Sister Claire, the nurse who had to teach us sex ed. There's nothing worse than a nun trying to teach you sex ed. Like, oh my God. Like, just I died 1,000 deaths. Yeah, I mean, so it impacted me because they didn't teach me anything. They just gave you the bare bones basics, and they didn't teach us anything about contraception, about consent, about anything. And what bothers me is that it's still going on. And so you saw in my recent Instagram post how few states actually mandate comprehensive, medically accurate sex education. Like, that's just bonkers to me. And so that's why I'm on social media, because you realize that even in 2020, people are still not being taught this stuff. How can we expect people to make good choices if they don't even know how their body works? So yeah, and that's why I'm so into advocacy, and I'm so into let's get these things on the ballot, because that's the only way you're going to change them. And that's why when people come into labor and they don't even know how things work, I'm just like, oh my God, we have to do better. So that's where my TikToks came from.
Thank you for that. And people are saying they have a good sense
Yeah.
of humor. And then the next question is,
No, you have to, because in this field, you're either laughing or you're crying all the time. So you cannot take yourself too seriously.
actually, that's a good segue to the question. Have you found times that it was hard to mask your emotions during
Mhm.
very emotional times, like
Mhm.
stillbirth?
Yeah. I think in those, I don't mask my emotions. The hardest time during a stillbirth is when you deliver the baby and that guttural cry that the dad makes, like when it's finally real to him. And I could sit there and be a stone, and try to be professional. But I don't. I mean, I'm going to cry too. I'm not going to sit there and bawl and, steal the show, but I'm a human too. And, that's just how our field is. The opposite is true. When somebody comes in and they've been pushing for 4 hours and the baby finally delivers, like, we're high fiving, we're having fun. Um, your emotions are what make you real. And I think that you only get comfortable with that over time. In the beginning, I didn't know as a resident, am I allowed to cry? Am I allowed to be angry? What do I do? I don't know. And I just had really good mentors. I don't think patients don't want robots, right? Like, you want somebody who understands, and it's part of our training. And for me, I've learned the best thing to say is that I have no idea how you're feeling right now. but I'm so sorry that this is happening. And I am going to help you the best way that I can. And there's no right way to feel right now, but I'm here right along with you. And you tell me what you need, and we go from there. But it can be really hard, but it's just about not masking your emotions, I think. That's not what people need.
Wow. Yeah, I definitely agree with that.
Mhm.
So our next question is going to be, do you suggest talking about your low MCAT or GPA in your personal statement?
I mean, I did because I wanted to give people a reason to not just put my application in the, oh my God, no way pile. So I did, and I just called it out, and I was like, I can't even remember. It's been so long, but I basically said, this, I feel like I'm gonna be a great doctor. Here's, my MCAT was not where it is. Here's why I think it happened. And here's what I've learned from it so that when I am in medical school, I will succeed on these tests. And yeah, I mean, I did. I called it out because I didn't want it to be the elephant in the room or a reason that they just didn't even want to invite me for an interview.
Can you elaborate your hours during your residency? Because some people are saying that they've heard that it's really tough and like long hours for OBGYN residency.
It is, but to be honest, every residency is hard. I don't think there's a huge variation. But by law, we are limited to 80 hours a week. And you might be like, oh my God, 80 hours. But before that, it used to be just like, I don't know, till you died. I don't know. Like you just would work like 36 hours straight. So they now have work hour restrictions. You can't work more than 24 hours, I think. And there might even be more. Like it might even be less than that. And you have to have a certain break. It changed after I graduated. Um, but the nice thing about my residency is that some rotations were easier than others. So you might have one rotation that was a clinic-based rotation, so you worked mostly clinic hours. And then another one might be longer, like when you're doing gyn-oncology, so cancer surgeries. I mean, those surgeries sometimes take 12 hours, and then you've got a pre-op and post-op, and so it would vary. Um, it was hard, but I would say it was a very finite time period. I can say that because I'm done now, but it really did go fast, and you have to learn so much in 4 years, which is what OB residency is. Um, and I will tell you, my best friends are the people I did residency with, the ones that I was awake with at 2 a.m. when we're going down to the cafeteria and we're exhausted and we're begging the cook to we know he's got like the special food in the back, and we're like, please, you understand, we're dying, labor and delivery is crazy. And or we're playing pranks on each other because it's shift number 6 in a row. Or, I mean, we had so much fun. And these are the people that every day I still will text or we'll run cases by each other or we'll just check on each other. So it's crazy, but it's like going to war together. I don't want to downplay actually going to war, but you're in this crazy time together, and you're learning so much, but it goes by quickly. And your first year out as an attending, you're like, oh God, I wish I'd done another 10 years of residency, because you're so petrified that you have to actually make the decisions now. So, but it's not terrible.
Thank you.
Mhm.
So the next question will be, can you talk about your on-call schedule and what it looks
Mhm.
like?
Yeah, so I'm lucky as an OB hospitalist. There is no on call. I just do my shifts. So I do a certain number of shifts a month, and those are just my shifts. Now, if you are an office, a generalist OBGYN, so you do a mix of it all. You do a little clinic, you do a little OR, you do a little labor and delivery. Maybe your group, maybe you're on one call, 1 out of every 7 days, which means that anybody who comes into the emergency room or labor and delivery, you get called for that. Or maybe it's less than that. Maybe it's once every 2 weeks if you've got a big group. Maybe it's every single night because you were in private practice by yourself, and oh my God, don't do that. That's terrible. But it just depends. And so those are things that when you're looking at what you want to do eventually practicing, you can kind of decide what is more palatable to you.
Thank you. The next question is, how important do you feel that is to have a focus in psychology and like learning bedside manners as a
Yeah,
doctor?
I think that's a great question. I think that I think it's up to you. It certainly doesn't hurt, but I don't think you need to do it. If I could tell you guys to take one class or focus on one thing, it would be on business. I suck at business. Negotiations, suck at it. I wish that I understood the business side of medicine a little bit better. There's a reason I'm employed by a hospital and not in private practice, because I don't want to manage that. But people like my husband, who's in private practice, he loves that stuff and he wants to get his MBA, which I think is crazy. Um, but that's, if I could have done that, that would have been awesome. if I'd taken a communications class, I think that would have been great. I think that we do teach these things in medical school more so now. They do focus on that. So if you can't get that in college, that's okay. But if you can, it's not going to hurt.
All right, so our very last question, unfortunately there's more, but our last question that we are going to have time for would be, have you ever seen pregnancy in trans patients? If so, is it medically challenging to deliver or treat different conditions?
I have, and here in Portland, Oregon, we have some fantastic clinics and providers, and I think just a community that's more welcoming. It's not medically more challenging. It is more challenging to deliver inclusive, respectful care, just because you have to remind yourself, you have to make sure that you're using the correct terminology. And so much, I think, is being, how do you referred to? Are you mom? Are you dad? Are you whatever? Instead of calling it breastfeeding, calling it chest feeding. And again, like, I'm in a city where we've got so many amazing practitioners, resources, lactation consultants, pediatricians. I mean, so many people. Where I did my residency, we have a whole clinic, a whole program for trans care. It's not the situation everywhere. And I think it will become more common, and I think it's great because, like I've said, not all women who birth, or not all people who birth are women, and vice versa. So if you do find yourself caring for somebody like that, I think the takeaway is to know that you're going to make a mistake and you're going to say something and be like, I meant this, and just own it and just work better, doing better the next time, which is the whole mantra of medicine, is that you're never going to be perfect, but you're always learning. God, that was a great way to wrap that up, wasn't that?
Also, do you have any final advice for pre-health students and pre-med students in general?
Yeah, I think my biggest piece of advice is just know what your why is. Work really hard. Don't let this pandemic get you down. See this as an opportunity to show that you can rise above some crazy stuff. And if you guys are still wanting in, despite all this craziness, like, we're happy to have you. So we would love to have you. So it's a great job security. So.
Great. Thank you so much, Dr. Lincoln. That was an amazing presentation and question and answer session. So we're super honored that we had the opportunity to host you today. For all my students, please bring your attention to this. Everybody whip out your cell phone and pull out your cameras. You guys can scan this QR code. We are working to keep pre-health shadowing free for all students, and we don't want any money to come from your guys' pockets. You guys are all students working to achieve your goals. All that we're asking is that you guys help us raise money. And so this QR code will lead you to our fundraising page where you guys can join our fundraising team. And by sending this out to different people, you guys are able to get volunteer hours. So this is a great way to get some virtual volunteer hours in. So go ahead, and I'll leave this up for a few moments. Be sure to scan that. Even if you don't send it out right now, just make sure you have it handy. And I'll go into details about volunteer hours in a few slides.
Nina, are you okay if I jump off? I think I just have to finish bedtime here.
Oh,
Thanks, guys, so much. This was so fun.
Bye-bye.
Bye, guys.
Thank you.
Thank you.
Thank you.
So our next announcement is we're going to do a little reflection. So this is for all of your students. You guys are going to be applying to various programs. And so just making sure that you guys are taking great notes, something that you guys can write about when you're doing your personal statement or you're answering the activities prompt and stuff like that. And so if you scan this QR code, this will take you to the speaker's course page. And at the very bottom, there will be a little comment section. So you can answer one of these 3 questions in the comments section, and you can send that in. And this is just a way for you guys to reflect on the session today. So I will leave this QR code up for a little bit. This will also be the page that you will be taking the quiz, which I will go into details in a couple slides. So I'll,
When I scanned the QR code, there was like an error.
okay, are other people receiving an error as well?
I'm also having this issue, and a lot of people in the chat are.
Yeah.
Okay, thank you for letting me know.
it's me too.
Thank you. Okay, we'll go ahead and skip over that for now. So I want to let you guys all know that we are taking applications to join our student team. This is 100% remote opportunity, a great opportunity to meet with like-minded students, not only in the United States, but all over the world. Great leadership opportunities opening up, and you can gain professional experience that is needed for thousands of health programs that you will potentially be applying to. It looks really great on any application, resumes, CVs. So just here is the application form. You can find this on our website as well under Join Our Team. If you currently are running low on time, we understand you guys are all pre-health students. You have a lot going on. We 1000% understand. There are volunteer opportunities. If you want to put in a couple hours here and a couple hours there, you can work from home on your own schedule. It could be at 3 in the morning. It could be at 1 in the afternoon. And so if you guys are interested, you can sign up to be a volunteer here. And I'll leave this up for a few more seconds. So our next announcement is if you would like to stay updated on the upcoming shadowing sessions and never miss a session, you can follow us on Instagram. And we have a challenge for you all today. And this will be to comment the professional's last name letter by letter. It's really difficult, so good luck with this. And if you are successful, you are potentially able to earn the opportunity to join and become our student of the session. So it's really exciting. It's very difficult, so everybody try it out. Another announcement is to tag us in your posts. So if you took a post today of you joining our pre-health shadowing session and you post that on any of your social media, be sure to tag us and you could potentially be on our official account. Also, if you guys want to make TikToks about pre-health shadowing, we 1000% accept that as well. Our next shadowing session is tomorrow morning at 10:30 Pacific Standard Time. Now, to get your certificate, the first step is to go to the speaker's course. So you want to go to Dr. Jennifer Lincoln page, and this will be under all shadowing sessions. She will be on the second page, so be sure that you are not just stuck on the first page. You have to look around a little bit. We do have a lot of speakers that are on our website now. You're going to want to click free take this course to the right of her picture. You will have 30 minutes to complete the assessment, and you will have 2 tries. I recommend if you pass the first time, even if it's with a 70 or an 80 and you're not necessarily happy with your final score will not show up on your certificate. So if you pass, take the certificate, because if you take it a second time and fail, your eligibility to receive your certificate goes away. So just keep that in mind. Once you pass the exam with a 70% or higher, you must return to the speaker's page and click Finish Course. If you do not click Finish Course, you will not receive your certificate, so please ensure that you do this. Your certificate can be downloadable immediately, or you can always find it in your profile under the Certificates tab. If you guys experience any difficulties or have any questions about this, feel free to email us at info@prehealthshadowing.com, and we will get back to you as soon as we can. This concludes our virtual shadowing session for tonight. Thank you all for joining, and have a beautiful evening.
Nina, stop recording.